Ultrasound is an imaging test that uses sound waves to create pictures of organs, tissues, and other structures inside the body. Unlike X-rays, ultrasounds don't use any radiation. Ultrasound can also show parts of the body in motion, such as a heart beating or blood flowing through blood vessels. There are two main categories of ultrasounds: pregnancy ultrasound and diagnostic ultrasound. Pregnancy ultrasound is used to look at an unborn baby. The test can provide information about a baby's growth, development, and overall health. Diagnostic ultrasound is used to view and provide information about other internal parts of the body. These include the heart, blood vessels, liver, bladder, kidneys, and female reproductive organs. To begin our interesting study, discussions on basic ultrasound instrumentation have historically focused on proper handling of the transducer and adjustment of controls for image optimization. Any ultrasound system has three basic components: a transducer, or probe, the processing unit, including the controls, and the display. Ultrasound transducer is a device that produces sound waves that bounce off body tissues and make echoes. The transducer also receives the echoes and sends them to a computer that uses them to create an image called sonogram. Positioning the probe during an ultrasound is very necessary. Every probe has an orientation notch that is a small marker or grooved line on one side of the probe. Begin by holding the probe with the thumb side of your hand near the orientation notch or groove. There are three standard described scan planes: body planes, coronal, sagittal, transverse. The beginner is generally advised to stay in these simple planes so as to be able to reliably obtain recognizable images repeatedly. This is what makes focused scanning feasible. With experience, changes in the inclination of planes helps to obtain improved images. When using the longitudinal orientation, hold the probe so that the orientation notch is pointing towards the patient's head. When using the transverse orientation, the notch should be towards the patient's right side. This will orient your screen to the corresponding plane. Thanks for watching. Share and subscribe for more.
Have you subscribed? Please kindly press subscribe button. A good knowledge of ultrasound will begin with the least unexpected aspects, as in receiving a patient. Greet the patient, introduce yourself, make the patient feel relaxed, ask opening questions. Direct the patient to an ultrasound examination bed, set the gel, the liquid used to fill the gap between the skin and the ultrasound transducer, so that there is no intervening air to interfere with ultrasound transmission. Now, we have learned on the handling, inclination techniques of a transducer. Have you ever looked at an ultrasound image and wondered what are you looking at? Ever wonder which end is up? When others are discussing Buller-Heifer, ovarian diagnosis, or metritis treatment, are you still looking to decide what it is? Well, if you feel left in the dark when it comes to ultrasound images, let's start back at the basics. Ultrasound is a non-invasive, immediate tool used to image tissue. It will not penetrate bone, like an X-ray. So the first step to help you read the ultrasound image is to be familiar with the anatomy that you are imaging. Various body tissues conduct sound differently. Some tissues absorb sound waves while others reflect them. The density of the tissue dictates the speed at which the echoes return. If you remember that fluid is always black and tissue is gray. The denser the tissue is, the brighter white it will appear in ultrasound, the brightest white being bone. After learning that fluids appear black, tissue appear gray, and bone appear white on ultrasound, now we need to understand the terms which are generally used. Anechoic. This term means without echoes. These areas appear black on ultrasound, because they do not send back any sound waves. Anechoic masses are often fluid-filled. Hypoechoic. This term means not many echoes. These areas appear dark gray because they don't send back a lot of sound waves. Solid masses of dense tissue are hypoechoic. Hyperechoic. This term means lots of echoes. These areas bounce back many sound waves. They appear as light gray on the ultrasound. They may contain air, fat, or fluid. Thanks for watching. Subscribe and share. Do you have lumps on your neck or behind your ear? This is what it means, and this is what you must do. Lumps can be pretty bothersome, so all and sundry who receives a lump in their physique is afraid of its fitness value as nicely as its appearance. It's now not common, however they are common. Small lumps on the neck or at the back of the ears are most common. These lumps are a kind of cyst referred to as an epidermal cyst, and they are specific from a sebaceous cyst. A sebaceous cyst is an end result of the mammary glands. There is no want to deal with an epidermal cyst, however many human beings favor to get rid of them due to the fact it can reason contamination in some instances and is unsightly. To get rid of an epidermal cyst, there is no want for clinical techniques due to the fact there are herbal redress that we will current to you today. Here is a listing of remedies that will assist you get rid of the lump on the neck or in the back of the ear. 1. Apple cider vinegar. Apple cider vinegar is very advantageous due to the fact of the acetic acid it contains. It eliminates the contamination and protects you from bacteria. Take some apple cider vinegar and observe it on the lump. Put a bandage or plaster to hold it. Do this each and every day for a week, till the cyst turns into a difficult layer of skin. Remove the layer and make positive the cyst can be drained. Then put some apple cider vinegar on the place for some other week, and your pores and skin will be easy again. Psoriasis is occasionally known as end-stage liver disease. It comes after the different levels of harm which can consist of irritation, hepatitis, fatty deposits, steatosis, and accelerated stiffness and mild scarring of your liver, fibrosis. Many humans with psoriasis can sense pretty properly and stay for many years, besides wanting a liver transplant. This is due to the fact the liver can notably function nicely, even when it is pretty severely damaged. Psoriasis is categorized as compensated or decompensated. Compensated psoriasis is the place the liver is coping with the injury and retaining its vital functions. In decompensated psoriasis, the liver is no longer capable to function all its features adequately. People with decompensated liver disorder or psoriasis regularly have serious signs and symptoms and issues such as portal hypertension, bleeding varices, ascites and hepatic encephalopathy. There are additionally structures for grading psoriasis in accordance to its severity. One of these is the Child-Pugh score, which makes use of signs together with encephalopathy and ascites collectively with blood. Take a look at outcomes for bilirubin, albumin and clotting to grade psoriasis from A, relatively mild, to C, severe. There are different structures which includes MELD, model of end-stage liver disease, which are used to assist figure out which sufferers most urgently want liver transplants. It makes use of blood. Take a look at consequences for bilirubin, creatinine and clotting, INR. Ovarian cysts are sacs, usually filled with fluid, in an ovary or on its surface. Females have 2 ovaries. One ovary is located on each side of the uterus. Each ovary is about the size and shape of an almond. Eggs develop and mature in the ovaries. Eggs are released in monthly cycles during the childbearing years. Ovarian cysts are common. Most of the time, you have little or no discomfort, and the cysts are harmless. Most cysts go away without treatment within a few months. But sometimes ovarian cysts can become twisted or burst open, rupture. This can cause serious symptoms. To protect your health, get regular pelvic exams and know the symptoms that can signal what might be a serious problem. Most ovarian cysts cause no symptoms and go away on their own. But a large ovarian cyst can cause pelvic pain that may come and go. You may feel a dull ache or a sharp pain in the area below your belly button toward one side. Fullness, pressure or heaviness in your belly, abdomen. Get immediate medical help if you have sudden, severe abdominal or pelvic pain. Pain with fever or vomiting. Signs of shock. These include cold, clammy skin, rapid breathing, and lightheadedness or weakness. Most ovarian cysts form as a result of your menstrual cycle. These are called functional cysts. Other types of cysts are much less common. Functional cysts: your ovaries grow small cysts called follicles each month. Follicles produce the hormones estrogen and progesterone and break open to release an egg when you ovulate. A monthly follicle that keeps growing is known as a functional cyst. There are two types of functional cysts: follicular cyst. About halfway through your menstrual cycle, an egg bursts out of its follicle. The egg then travels down a fallopian tube. A follicular cyst begins when the follicle doesn't rupture. It doesn't release its egg and continues to grow. Corpus luteum cyst. After a follicle releases its egg, it shrinks and begins producing estrogen and progesterone. These hormones are needed for conception. The follicle is now called the corpus luteum. Sometimes, the opening where the egg came from gets blocked. Fluid builds up inside the corpus luteum, causing a cyst. Functional cysts are usually harmless. They rarely cause pain and often disappear on their own within 2 to 3 menstrual cycles. There are other types of cysts that are not related to menstrual cycles. Dermoid cyst. Also called a teratoma, this cyst forms from reproductive cells that make eggs in the ovary, germ cells. The cyst can contain tissue, such as hair, skin or teeth. This type of cyst is rarely cancer. Ovarian teratomas are a type of tumor or mass that develop on the ovaries. The majority are non-cancerous and require surgery to remove them. Teratomas are a type of tumor or mass of cells that develop from one or more layers of germ cells, which are the cells that help form the male and female reproductive systems. The majority of teratomas that occur on the ovaries are benign, with only a few being cancerous. Anytime a woman is having unusual pain in her pelvis, she should check in with a healthcare professional. The doctor will be able to perform a pelvic exam or order additional diagnostic tests to help figure out the source of the pain. Complications associated with ovarian pain depend on what is causing the discomfort. Thanks for watching. Please subscribe, like and press on notification bell. Gynecological sonography is an important diagnostic modality commonly used to evaluate emergent conditions and many common gynecological disorders. Knowledge of the anatomy and physiology of the female pelvis is an important prerequisite in obtaining and interpreting gynecological sonographic images. The transducer should be selected to operate at the highest clinically appropriate frequency that will allow adequate visualization of deep pelvic structures. For transabdominal evaluation, a 3.5 MHz or higher transducer is employed. Curved linear array, as well as sector transducers with a smaller footprint, are often employed. For transabdominal evaluation, The bladder should be adequately distended to displace bowels superiorly out of the true pelvis and provide an acoustic window to visualize the uterus and adnexa. The uterus is an extraperitoneal hollow, thick-walled, muscular organ of the female reproductive tract that lies in the lesser pelvis. It is inverted pear shape. It measures about 7.5 centimeters in length, 5 centimeters wide at its upper part, and nearly 2.5 centimeters in thickness in adults. It weighs approximately 30 to 40 grams. The uterus is a hollow organ in which the myometrium is firmly adherent to a thin internal layer of endometrium. Externally, the uterus is embedded between the two layers of the broad ligament. Anatomically, the uterus lies between the bladder anteriorly and the rectosigmoid colon posteriorly. The uterus is divided into two major parts, the body and cervix. The most superior aspect of the uterus is referred to as the fundus, and the entrance of the fallopian tubes into the uterus are referred to as the cornua. About midway between the apex and base is a slight constriction known as the isthmus. The portion above the isthmus is termed the body, and that below, the cervix. The part of the body which lies above a plane passing through the points of the entrance of the uterine tubes is known as the fundus. The body gradually narrows from the fundus to the isthmus. Anterior to the origin of the fallopian tubes are the round ligaments, one on each side, which extend anterolaterally, coursing through the inguinal canals and inserting onto the fascia of the labia majora. The uterus has a dual blood supply. The majority of blood supply is from the uterine arteries arising from the internal iliac arteries, and a minor blood supply is from the ovarian arteries. The uterus is physiologically most often anteroverted and anteroflexed, but may also be retroflexed or retroverted. The cervix of the uterus is fixed in the midline, but the body of the uterus can be mobile and may change with varying degrees of bladder and rectal distension. Descriptions of flexion refer to the relationship of the body of the uterus to the cervix. Usually the angle is about 270 degrees, whereas version refers to the cervical relationship to the vagina. The vagina, uterus, and the urinary bladder are used as reference points for identification of the remaining normal and abnormal pelvic structures. The uterine size, shape, and orientation should be identified and documented in sagittal and transverse axial planes. The endometrium, myometrium, and cervix should be carefully evaluated and their appearance documented. The uterine length is measured in long axis from the fundus to the cervix, and the anteroposterior dimension is measured on the same image perpendicular to the length. The width is to be measured on a separate image on either a transaxial or coronal plane of section. If the volume of the uterine corpus is assessed, the cervical component should be excluded. Follow our next study on the ovaries, adnexa, and fallopian tubes. Then we continue with identification of pathologies. Thanks for watching. Subscribe and press notification.
The gestational sac is a fluid-filled structure surrounding an embryo during the first few weeks of embryonic development. It is the first structure seen in pregnancy by ultrasound as early as 4.5 to 5 weeks of gestational age and is 97.6% specific for the diagnosis of intrauterine pregnancy, meaning it is the only available structure that can be used to determine if an intrauterine pregnancy exists until the embryo can be identified. Its diameter is about 2 mm and increases in size to measure 5-6 mm at 5 weeks. The mean gestational sac diameter then increases by approximately 1 mm per day throughout the first trimester. The gestational sac, being a large cavity of fluid surrounding the embryo during early embryogenesis, consists of the extraembryonic coelom, also called the chorionic cavity. The gestational sac is normally contained within the uterus. It provides an embryo with nourishment, food. It helps circulate gases between mother and the embryo. The yolk sac also produces cells that turn into important structures, such as the umbilical cord, blood cells and reproductive organs. An abnormally shaped gestational sac or yolk sac should raise concern for a failing pregnancy. The gestational sac should normally be round or oval. An irregular gestational sac with angulations or teardrop shape is associated with a poor prognosis. The advent of ultrasound has allowed a more direct means of assessing fetal structures and development. Measurements of a wide variety of parameters have been devised to establish gestational age. Ultrasound assessment of gestational age is feasible in a majority of pregnancies and may be used to establish gestational age with greater accuracy than physical examination. The gestational sac is an echo-free space containing the fluid, embryo, and extraembryonic structures. The sac is measured inside the hyperechoic rim, including only the echo-free space. The gestational sac is imaged first in the longitudinal plane, obtaining long axis and anteroposterior measurements perpendicular to each other. Then, in the transverse plane at the level of the anteroposterior measurement, the width measurement is obtained. The three measurements are averaged to obtain the gestational sac mean diameter. In other words, the gestational age of the embryo is determined by measuring the mean diameter of the sac, as measured from inside wall to inside wall of the sac. If the gestational sac is not completely round, then it may be measured using three orthogonal distances from the inside of the sac, using sagittal and transverse views. The mean sac diameter is then either compared to a table of values, input into a regression model, or input into the ultrasound machine, determining the estimated age through preset calculators on an obstetric setting. Thanks for watching. Learning is fun. Subscribe for more. Ultrasonography is a commonly used tool to evaluate the status of pregnancy. Complications arising from pregnancy are frequently encountered complaints in emergency departments and prenatal clinics. Though home pregnancy tests are increasingly popular, some women may discover they are pregnant for the first time in the outpatient setting. A true gestational sac can be distinguished from a pseudogestational sac by noting these points. 1. Its normal eccentric location. It is embedded in the endometrium rather than centrally within the uterine cavity. 2. Presence of the double decidual sign, most helpful at 4 to 6 weeks. 3. Presence of a yolk sac. Seen at approximately 6 weeks, unequivocal evidence of a gestational sac. However, caution should be exercised with a diagnosis of a pseudogestational sac. In a woman with a positive beta-HCG, any intrauterine sac-like fluid collection seen on ultrasound is highly likely to be a gestational sac. An irregular gestational sac, lack of a smooth contour and/or presence of a distorted sac shape is highly suggestive of an abnormal intrauterine pregnancy. First trimester ultrasounds are not a requirement for all pregnancies to confirm viability. However, if any high-risk features, such as advanced maternal age, twin pregnancy, and/or clinical concerns are present, such as irregular menses, vaginal bleeding, more than one ultrasound may be performed at the clinician's discretion. With the first ideally in the late first trimester between 10 and 13 weeks. However, ultrasound exams before 10 weeks are common and can still be used as accurate assessments for most necessary clinical determinations. It may be utilized as a part of the standard evaluation during pregnancy or to elucidate other concerning signs and symptoms. Missed abortion as a pregnancy complication. Missed abortion is when a pregnancy stops developing, where the embryo-fetus embryonic tissue or empty gestation sac remains in the uterus and the cervical os is closed. Symptoms may include pain, bleeding or no symptoms at all. If an ultrasound is done, the scan may show an embryo or fetus without cardiac activity or what appears to be an early developing pregnancy, with only a fluid-filled sac visible within the uterus. Medical, surgical, vacuum aspiration, and expectant management are all options for management of missed abortion. The causes of missed abortion are not fully known. About 50% of miscarriages happen because the embryo has the wrong number of chromosomes. Sometimes, miscarriage may be caused by a uterine problem like scarring. You may be at higher risk for missed miscarriage if you have an endocrine or an autoimmune disorder or are a heavy smoker. Physical trauma can cause a missed miscarriage as well. Ultrasound diagnosis of miscarriage should only be considered when either a mean gestation sac diameter is greater than or equals to 25 mm, with no obvious yolk sac, or a fetal pole with a crown rump length of greater than or equals to 7 mm, without evidence of fetal cardiac activity. Transvaginal ultrasound is the mainstay in the diagnosis of miscarriage. Once the diagnosis of miscarriage is made based on the above ultrasound criteria, the patient can then be offered different types of management depending on their clinical status and patient's choice. Expectant management is possible, with a wait-and-watch approach offered after careful counseling to women who have met the inclusion criteria. Was quite easy, right? Learning is fun. Subscribe for The blighted ovum, also called an anembryonic pregnancy, occurs when an early embryo never develops or stops developing, and it is resorbed and leaves an empty gestational sac. The reason this occurs is often unknown, but it may be due to chromosomal abnormalities in the fertilized egg. Blighted ovum usually occurs early in pregnancy, sometimes before you even know you're pregnant. However, you may be aware of your early pregnancy because of a positive pregnancy test or missed menstrual period. A pregnancy test may be positive because the early embryo secretes a pregnancy hormone, human chorionic gonadotropin (HCG), until the embryo stops developing and fails to implant. You may have symptoms of early pregnancy, such as breast tenderness, nausea and vomiting. But when the embryo stops growing and hormone levels decrease, pregnancy symptoms subside. At this point, minor abdominal cramping and light spotting or bleeding are possible. An ultrasound will show an empty gestational sac. A blighted ovum eventually results in miscarriage. Some women choose to wait for the miscarriage to happen naturally, while others take medication to trigger the miscarriage. In some cases, a procedure called dilation and curettage (D&C) is used to remove the placental tissues. Most women who have had a blighted ovum go on to have successful pregnancies. If you experience multiple consecutive miscarriages, talk with your doctor or other care provider to identify any underlying causes. A blighted ovum will eventually cause a miscarriage, usually at 7 to 12 weeks of pregnancy. Your body realizes that the pregnancy is not developing properly and starts to shed blood and tissue from the uterus. What is the main cause of blighted ovum? A blighted ovum is usually caused by chromosomal or genetic problems during cell division. During conception, the egg will begin to divide shortly after being fertilized by sperm. Around 10 days later, the cells have formed an embryo. With a blighted ovum, the embryo never forms or stops growing after it's formed. How common is a blighted ovum? Blighted ovum is the most common cause of miscarriage. Experts estimate that blighted ovum accounts for about 50% of all miscarriages in the first trimester. About 15% of all pregnancies end in miscarriage before 13 weeks of pregnancy. Statistics show you will likely have a normal and healthy pregnancy in the future, even immediately after a blighted ovum. In a study involving women with early miscarriages, around 80% were able to have a successful pregnancy within the next 5 years. Treatment for blighted ovum. After a pregnancy loss, the placenta and sac need to leave the body. The process can cause pain and bleeding. This can happen on its own, or your body may need help. When a fertilized egg doesn't become an embryo, this type of miscarriage occurs. While your HCG levels may have triggered a positive pregnancy test, They're not likely to rise any further and will instead stay low. There are also a number of reasons why a blighted ovum can be misdiagnosed. During an early pregnancy visit, your doctor will typically use an ultrasound to look for signs of a viable pregnancy. If the doctor sees what they believe is an empty embryonic sac, they may tell you that you have a blighted ovum. That was quite easy. Ultrasound made easy. Learning is fun. Press subscribe button. Crown rump length is an ultrasound measurement that is used during pregnancy. The baby is measured in centimeters, from the top of their head crown to the bottom of their buttocks rump. The limbs and yolk sac are not included in the measurement. The crown rump length can be measured starting around 6 or 7 weeks of pregnancy up until 14 weeks. The crown rump length is the longest length of the embryo or fetus measurable excluding the limbs and yolk sac. The embryo becomes a fetus after 10 gestational weeks, that is, 71 completed days based on the LMP. The accuracy of the crown rump length LN dating the pregnancy depends on good correlation between this measurement and fetal age in a period when growth is rapid and minimally influenced by fetal pathology. Crown rump length is thus very useful in calculating gestational age. With this gestational age, doctors can estimate your potential due date. The earlier the first ultrasound is performed, the more accurate the baby's gestational age will be. Once the fetus has developed past 14 weeks, head circumference, biparietal diameter, and femur length measurements are used to determine how the baby is progressing. The length of the umbilical cord is typically the same as the crown rump length throughout pregnancy. The crown rump length is predictive of fetal age, with an error of 3 days, 90% confidence limits, from 7 to 10 weeks, and of 5 days from 10 to 14 weeks gestation. The crown rump length grows approximately 10 mm per week from weeks 8 to 12. The crown rump length of the fetuses, in a case of multiple gestation, is the most important ultrasound parameter for dating of the pregnancy and, if necessary, to correct the gestational age in cases with a non-reliable menstrual history. The onset of early growth retardation in one of the fetuses may indicate a higher risk for chromosomal abnormalities. Once the fetus's crown rump length surpasses 7 mm, a heartbeat should be detected by ultrasound. If no heartbeat or cardiac activity is detected, then the pregnancy is likely a missed abortion. Normally, the crown rump length correlate between co-twins, although some degree of variability has been observed in multifetal pregnancies. Measurement of the crown rump length can easily be done at the time of the first trimester scan, 11-14 weeks of gestation. Later in pregnancy, correction of gestational age should be avoided, since growth curves in multiple pregnancies differ from those in singleton pregnancies beyond the second trimester. There are no significant differences with measurements made by the transabdominal route or the transvaginal route. Because transvaginal scan provides superior resolution and more accurate identification of the embryonic structures than abdominal ultrasound. The accuracy of crown rump length measurements in determining gestational age is within 3-5 days. There is an optimum window for crown rump length measurement, which is between 7 and 9 weeks using transvaginal scan. Decreased crown rump length can also diagnose chromosomal anomalies like trisomy 18, which is Edwards syndrome, and other trisomies associated with growth restriction. Standard embryology texts indicate that the embryonic heart begins to beat at the beginning of the 6th week, when the crown rump length is 1 to 3 mm. Thus it is not surprising that cardiac activity may or may not be identified in normal embryos with crown rump length less than 2 mm. Thanks for watching. Please do subscribe for the first trimester. Fetal development. 0 to 13 weeks. The first trimester is most crucial to your baby's development. During this period, your baby's body structure and organ systems develop. Most miscarriages and birth defects occur during this period. Your baby also undergoes major changes during the first trimester. That is, 1. All major systems and organs begin to form. 2. The embryo looks like a tadpole. 3. The neural tube, which becomes the brain and spinal cord, the digestive system, and the heart and circulatory system, begin to form. 4. The beginnings of the eyes and ears are developing. Ultrasound screening is indicated in the screening of first trimester pathologies. Report published in 2005 that the ultrasound scan performed during the first trimester of pregnancy must check that the fetus does not present any cranial or midline anomalies. Major structural anomalies detected during the first trimester scan are highest rates corresponding to 1. Acrania. 2. Holoprosencephaly. 3. Hypoplastic left heart syndrome. 4. Omphalocele. 5. Megacystis. 6. Hydrops, and 7. Anencephaly. What is acrania? Acrania, a neural tube defect, is a condition characterized by the partial or complete absence of the fetal skull. The face and base of the skull are present, but due to the malformation of the skull, the brain is exposed. Acrania is considered the early gestation precursor to anencephaly. The progression from exposed brain tissue that appears normal, acrania, to no recognizable brain tissue, anencephaly, is called the fetal acrania anencephaly sequence. Thus, acrania refers to the absence of a fetal skull with freely exposed brain tissue to amniotic fluid. Acrania often results in anencephaly, and some believe it is a precursor to all cases of anencephaly. Both can be seen on ultrasound in the first trimester. Acrania is a rare congenital disorder that occurs in the human fetus, in which the flat bones in the cranial vault are either completely or partially absent. The cerebral hemispheres develop completely but abnormally. The fetus is said to have acrania if it meets the following criteria. The fetus should have a perfectly normal facial bone, a normal cervical column, but without the fetal skull, and a volume of brain tissue equivalent to at least 1/3 of the normal brain size. There are no known family ties in acrania, and recurrence rates are extremely low. Not much is known about the exact mechanism involved in acrania. It is hypothesized that, like other developmental malformations, there are multiple origins for acrania. During the 4th week of human development, the neuropor in a normally developing fetus closes. When this process is either interrupted or never initiated, acrania occurs. Acrania can be diagnosed early in pregnancy through an ultrasound. This abnormality appears during the beginning or end of the 4th week of the fetus's development. An absence of the skull is needed in order to make a diagnosis. A presence of brain tissue will confirm the diagnosis of acrania and differentiate it from other developmental problems such as anencephaly. Newborns who survive die within several hours, days, or weeks. This disease is rare, occurring in 1 in 20,000 live births. In order to better manage an acrania diagnosis, early detection is of extreme importance. Sadly, there is no medical treatment for acrania. Due to the lack of development of babies' brains, about 75% of infants are stillborn, and the remaining 25% of babies die within a few hours, days, or weeks after delivery. Care focuses on providing emotional support to your family. Can acrania be misdiagnosed? It is suggested that there is lacking of mesenchymal migration in the 4th week of embryological age. The first trimester diagnosis must be made with restraint because the fetal cranium is not fully calcified before 10 to 11 weeks. Therefore, if only mid-sagittal views of the fetus are obtained, misdiagnosis may occur. Getting adequate amounts of folate and folic acid can prevent neural tube defects like acrania. All women of childbearing age should get 400 micrograms (mcg) of folic acid daily, prior to and throughout pregnancy. For women who have experienced a prior pregnancy affected by neural tube defects, A high daily dose of 4 mg of folic acid is recommended, starting at least 4 weeks prior to conception. Thanks for watching. Learning is fun. Please right away press subscribe buttons before Alloprosencephaly is a disorder caused by the failure of the prosencephalon, the embryonic forebrain, to sufficiently divide into the double lobes of the cerebral hemispheres. The result is a single-lobed brain structure and severe skull and facial defects. Simply put, holoprosencephaly is an abnormality of brain development in which the brain doesn't properly divide into the right and left hemispheres. The forebrain is a region of the brain in the fetus that develops into parts of the adult brain, including the cerebral cortex. Instead of the normal complete separation of the left and right halves of the forebrain, there is an abnormal continuity between the two sides. The condition can also affect development of the head and face. There are 4 types of holoprosencephaly, distinguished by severity. From most to least severe. The 4 types are: 1. Allobar. In the allobar form, there is no separation between the right and left halves at all. 2. Semilobar. In semilobar form, at least some separation of the two halves is present. 3. Lobar. In the lobar form, most of the brain has separated into right and left sides, though there is incomplete division into the two halves. And 4. Middle interhemispheric variant. In general, the severity of any facial defects corresponds to the severity of the brain defect. The most severely affected people have one central eye, cyclopia, and a tubular nasal structure, proboscis, located above the eye. In the less severe forms, the brain is only partially divided and the eyes usually are set close together. Other signs and symptoms often include intellectual disability and pituitary gland problems. Holoprosencephaly can be caused by genetic changes in any of at least 14 different genes, chromosome abnormalities, or agents that can cause birth defects, teratogens. Holoprosencephaly is a birth defect that arises during the first few weeks of the pregnancy. Diabetes in the mother during the pregnancy can increase the risk of holoprosencephaly in the fetus. However, for most children, no known intrauterine exposure is identified that is causally related to holoprosencephaly in that child. Some children will have an identifiable genetic cause of holoprosencephaly. Approximately 1/3 of children born with holoprosencephaly have an abnormality of the chromosomes, which contain the genetic material, DNA. The most common chromosomal abnormality associated with holoprosencephaly is when there are 3 copies of chromosome 13, trisomy 13, although a number of other chromosomal changes can also cause holoprosencephaly. Despite the above understanding of the causes of holoprosencephaly, the exact cause of the condition is not identified for many individuals. There are likely to be additional genetic causes other than those already known and mentioned above. Treatment and care for the issues associated with holoprosencephaly are supportive and based on the specific medical issues present for an individual child. An endocrinology evaluation should be performed to assess for pituitary abnormalities. A neurologist should also be involved in the child's care and can guide treatment for seizures if they are present. Plastic reconstructive surgery of cleft lip and palate or other facial features may be needed if indicated. A developmental pediatrician can help direct developmental therapies. Other treatments can be instituted as appropriate. A clinical genetics evaluation and genetic counseling should be obtained for patients and their families once the diagnosis is made. Children diagnosed with this disorder may have a small head, microcephaly, excessive fluid in the brain, hydrocephalus, facial abnormalities, tooth abnormalities, single central incisor, cleft lip and/or palate, epilepsy, and/or endocrine abnormalities. The most severely affected individuals may have cyclopia, a single central eye that is the most severe eye finding seen in holoprosencephaly, though this is very rare. Abnormalities in the formation of the nose may also occur. Holoprosencephaly may also affect other systems in the body. Defects in the pituitary gland can cause an abnormally low level of sugar in the blood, hypoglycemia, low levels of sodium in the blood, or genital abnormalities. An endocrinology evaluation should be performed to assess for pituitary abnormalities. A neurologist should also be involved in the child's care and can guide treatment for seizures if they are present. Plastic reconstructive surgery of cleft lip and palate or other facial features may be needed if indicated. A developmental pediatrician can help direct developmental therapies. Other treatments can be instituted as appropriate. Thanks. Learning is fun. But please right away, press subscribe button before the lectures begin. Human chorionic gonadotropin, HCG, is a hormone produced by the body during pregnancy. It supports fetal growth. Doctors test HCG levels in the urine and blood to confirm pregnancy. They also use HCG blood tests to help determine if a person could be experiencing an ectopic pregnancy or miscarriage. Pregnancy, ectopic pregnancy, and miscarriage will never be diagnosed based on one HCG level alone, but it's helpful to know how these levels work in such cases. If you think you're pregnant, a doctor will test blood drawn from a vein to check your HCG levels. If you don't have any HCG present in your blood, this doesn't necessarily mean you aren't pregnant. You may be too early in your pregnancy for your HCG levels to increase. HCG levels higher than 5 million international units per milliliter, (μml), typically indicate pregnancy. Your first test result is considered a baseline level. This level can range from very small amounts of HCG, such as 20 μml or even lower, to larger amounts, such as 2,500 μml. The baseline level is important because of a concept doctors call doubling time. In the first 4 weeks of a viable pregnancy, HCG levels will typically double about every 2 to 3 days. After 6 weeks, the levels will double about every 96 hours. So, if your baseline level is higher than 5 μml, your doctor may order you repeat the test a couple of days later to see if the number doubles. In the absence of certain risks, one additional level may be enough to determine pregnancy. In many cases, your doctor will then recommend you have an ultrasound sometime between 8 and 12 weeks as part of first trimester pregnancy care. If you're at risk for miscarriage or an ectopic pregnancy, you're more likely to have HCG levels that don't double. They may even decrease. Therefore, your doctor may ask you to return to their office 2 to 3 days after your baseline blood test to see if your level has doubled appropriately. If your HCG levels don't come close to doubling after 48 to 72 hours, your doctor may have concerns that the pregnancy is at risk. Medically, this may be called a possible non-viable pregnancy. If your levels are dropping or rising too slowly, you'll probably be sent for other testing as well. This could include progesterone blood tests and a transvaginal ultrasound to check your uterus for a gestational sac. Other symptoms, such as bleeding or cramping, will also be taken into account. Missed abortion is when a pregnancy stops developing, where the embryo-fetus embryonic tissue or empty gestation sac remains in the uterus and the cervical os is close. In the event of a miscarriage, HCG levels typically decrease from previous measurements. For example, a baseline level of 120 μml that's dropped to 80 μml 2 days later can indicate the embryo is no longer developing and the body isn't producing more hormones to support its growth. Likewise, levels that aren't doubling and are only rising very slowly, for example, from 120 μml to 130 μml over a period of 2 days, can indicate a non-viable uterine pregnancy in which a miscarriage may take place soon. Levels that are slow to rise can also indicate a non-uterine pregnancy, which happens when the fertilized egg implants somewhere outside the uterus, usually the fallopian tubes. Because an ectopic pregnancy can be a medical emergency, it's important a doctor identify this as quickly as possible. On the other hand, it's also possible to have doubling HCG levels with an ectopic pregnancy. This is why HCG levels alone aren't enough to determine what's going on with 100% accuracy. HCG appears in the blood and urine of pregnant women as early as 10 days after conception. This test is also done to diagnose abnormal conditions not related to pregnancy that can raise HCG level. Results are given in international units per milliliter, ml. Normal levels are found in non-pregnant women. Less than 5 mmol men. Less than 2 mmol in pregnancy, HCG level rises rapidly during the first trimester and then declines slightly. The expected HCG ranges in pregnant women are based on the length of the pregnancy. 3 weeks. 5 to 50 mmol. 4 weeks. 5 to 426 mmol. 6 weeks. 1080 to 56,500 mmol. 7 to 8 weeks. 7650 to 229,000 mmol. 9 to 12 weeks. 25,700 to 288,000 mmol. 13 to 16 weeks. 13,300 to 254,000 mmol. 17 to 24 weeks. 4060 to 165,400 mmol. 25 to 40 weeks. 3640 to 117,000 mmol. Non-gravid. 55 to 200 ng per milliliter. Normal value ranges may vary slightly among different laboratories. Thanks for watching. Please subscribe. Dedicated to my viewer. Hypoplastic left heart syndrome is a birth defect that affects normal blood flow through the heart. As the baby develops during pregnancy, the left side of the heart, including the mitral valve, left ventricle, aortic valve, ascending aorta and aortic arch, does not form correctly. The left side of the heart is extremely underdeveloped. Hypoplastic left heart syndrome is one type of congenital heart defect. Congenital means present at birth. Because a baby with this defect needs surgery or other procedures soon after birth, hypoplastic left heart syndrome is considered a critical congenital heart defect. Hypoplastic left heart syndrome affects a number of structures on the left side of the heart that do not fully develop. The left side of the heart can't pump blood well. For example, the left ventricle is underdeveloped and too small. The mitral valve is not formed or is very small. The aortic valve is not formed or is very small. The ascending portion of the aorta is underdeveloped or is too small. Often, babies with hypoplastic left heart syndrome also have an atrial septal defect, which is a hole between the left and right upper chambers, atria, of the heart. In a baby without a congenital heart defect, the right side of the heart pumps oxygen-poor blood from the heart to the lungs. The left side of the heart pumps oxygen-rich blood to the rest of the body. When a baby is growing in a mother's womb during pregnancy, there are two small openings between the left and right sides of the heart. The patent ductus arteriosus (PDA) is a blood vessel that connects the pulmonary artery to the aorta, allowing blood to continue circulating directly into the aorta and out to the rest of the body, bypassing the lungs and the defective left side of the heart and the patent foramen ovale. Normally, these openings will close a few days after birth. In babies with hypoplastic left heart syndrome, the left side of the heart cannot pump oxygen-rich blood to the body properly. During the first few days of life for a baby with hypoplastic left heart syndrome, the oxygen-rich blood bypasses the poorly functioning left side of the heart through the patent ductus arteriosus and the patent foramen ovale. The right side of the heart then pumps blood to both the lungs and the rest of the body. However, among babies with hypoplastic left heart syndrome, once the PDA closes a few days after birth, blood flows to the lungs and then to the left side of the heart, where it is blocked and can't circulate through the rest of the body. It becomes hard for oxygen-rich blood to get to the rest of the body. Most infants die within the first 2 weeks of life. Some patients with hypoplastic left heart syndrome, however, can survive beyond 60 days without any surgical intervention through the development of pulmonary hypertension. Women can take steps before and during pregnancy to reduce the risk of having a baby born with birth defects. Such steps include taking a daily multivitamin with folic acid, 400 micrograms, not smoking, and not drinking alcohol during pregnancy. Treatment of hypoplastic left heart syndrome requires medication. A continuous infusion of prostaglandin E1 (PGE1) is needed to maintain ductal patency. To prevent closure of the connection ductus arteriosus between the right and left sides of the heart. Plus, either surgery or a heart transplant is necessary. Advances in care have improved the outlook for babies born with this condition. Symptoms: babies born with hypoplastic left heart syndrome usually are seriously ill soon after birth. Symptoms include 1. Grayish-blue color of the lips and gums, cyanosis. 2. Rapid, difficult breathing. 3. Poor feeding. 4. Cold hands and feet. 4. Weak pulse. 5. Being unusually drowsy or inactive. If the natural connections between the heart's left and right sides, foramen ovale and ductus arteriosus, are allowed to close in the first few days of life in babies with hypoplastic left heart syndrome, they can go into shock and possibly die. Most babies with hypoplastic left heart syndrome are diagnosed either before birth or soon after. However, seek medical help if you notice that your baby has any of the symptoms of the condition. Hypoplastic left heart syndrome occurs in the womb when a baby's heart is developing. The cause is unknown. However, having one child with hypoplastic left heart syndrome increases the risk of having another with a similar condition. A diagnosis of hypoplastic left heart syndrome is confirmed with an echocardiogram. It shows a small left ventricle and aorta. The echocardiogram might also show issues with heart valves. Because this test can track blood flow, it shows blood moving from the right ventricle into the aorta. And an echocardiogram can also identify other heart conditions, such as an atrial septal defect. Please kindly press subscribe button for follow-up each time a video is uploaded. Press subscribe. Most parents today will want to find out the sex of their baby before birth. One of the most common ways to do this is with an ultrasound, most frequently performed at between 18 and 20 weeks. And even above 20 weeks. You can find out the sex of your baby during a scan that is performed to check that your baby is healthy. Between weeks 18 and 20, a trained sonographer will perform a detailed anatomy scan called a level 2 ultrasound. By this stage of fetal development, you should be able to find out the sex of your baby. While telling the difference can sometimes be tricky, there are a few things the sonographer will look for to make the determination. We can be 95% accurate at this early stage of pregnancy. First, you need to be familiar with the handling of the transducer. With a convex transducer transabdominally, the patient is made to lie on an examination bed with the transducer sagittally, cursor pointing upwards towards patient head. Scan from the pubic region of the mother through the umbilicus, then follow through the lie of the baby. If the baby is in a cephalic position, at the pubic region of the mother, scan through the fetal head, abdomen then to the buttock of the baby to the thigh. At this lever of the thigh is where you calculate the femur length for dating. Then slight manipulating of the transducer from supine to transverse position at that level of the buttock to get across the two thighs, in between the thighs then, we get the sex of the baby clearly. Quite easy, right? Try it. Baby boy ultrasound signs. Flow of urine. The flow of urine can sometimes be spotted in a fetus. If it is moving upward, then it is more likely a boy. Male genitalia. Often be seen by weeks 18 to 20, the presence of male genitalia, including testicles, scrotum, and penis, is a clear sign of male sex. The scrotal sac and the penis are very much always and often the basic signals of always identifying baby boy. Used in 90% of cases. Sagittal sign. If the caudal notch is pointing upward at more than a 30-degree angle, then the fetus is a boy. If it is somewhere in between, it may be harder to make a definitive determination. Baby girl ultrasound signs. For girls, there are two signs to look for: hamburger sign. This is the moniker given to the appearance of the labia and clitoris on an ultrasound. If you look closely at the image, you will see that the labia lips would look similar to a hamburger bun, while the clitoris would resemble the hamburger patty. Sagittal sign. Each sex has a sagittal sign. It is obtained by looking at a profile view of the fetus, known as the midline sagittal plane. There is a nub at the end of the spine, called the caudal notch. If it is pointing downward at a 10-degree angle, then the fetus is a girl. This 19-week ultrasound also shows a clear 3 white lines for a baby girl. So even though this baby is a bit younger than some of the other images, there is a better image, making it easier to discern if the baby is a girl or boy. This is another baby girl a bit further along into the pregnancy at 20 weeks. You can see the 3 lines, though not as clearly as some ultrasound images. Sometimes this lack of clarity has to do with the ultrasound equipment, the mother's weight, the baby's size. There are many factors involved in getting a clear picture from an ultrasound. The ultrasound technician has marked this one a girl as well. This 20-week ultrasound is a bit more obvious if you're looking for the classic hamburger sign of 3 white lines. The 3 white lines, which are actually the labia with the clitoris in the middle, can resemble 2 buns and the meat of a hamburger. This image is more easily defined as you can see the baby's thighs, too. These landmarks make it easier to tell what you are looking at, particularly when it is a photo and not a video. It's a girl for sure. That's what the ultrasound technician said at the look of this 20-week ultrasound. This baby helped make the diagnosis of girl a bit easier with the space between her legs. When you have your ultrasound done, remember that while the technician's call is usually right, sometimes mistakes happen. There are many reasons why your ultrasound might be wrong when it says girl or boy. These possible hiccups are usually controlled for in a variety of ways, but also you should have the limitations of your exam explained to you in a way that you can understand. Understanding the limitations of ultrasound technology will give you a better idea of how seriously you should take the results and how much decorating you should do in the baby's room or in a baby's wardrobe. God blessed you as you watched my videos. May God Almighty grant your heart desires. Are you looking for baby boy or girl? May it be granted to you in Jesus' name. Fibroids, also known as leiomyoma, is benign tumor of muscular and fibrous tissues, typically developing in the wall of the uterus. It is thought they occur more often in overweight or obese women because being overweight increases the level of estrogen in the body. Women who have had children have a lower risk of developing fibroids. Fibroids can grow anywhere in the uterus and vary in size considerably. Some can be the size of a pea, whereas others can be the size of a melon. The main types of fibroids are: 1. Intramural fibroids. The most common type of fibroid, which develop in the muscle wall of the womb. 2. Subserosal fibroids. Fibroids that develop outside the wall of the womb into the pelvis and can become very large. 3. Submucosal fibroids. Fibroids that develop in the muscle layer beneath the womb's inner lining and grow into the cavity of the womb. 4. In some cases, subserosal or submucosal fibroids are attached to the womb with a narrow stalk of tissue. These are known as pedunculated fibroids. If your doctor thinks you may have fibroids after performing the exam, there are several tests that can confirm the diagnosis. The first is usually an ultrasound. The other tests are more specialized and are only performed if needed to guide treatment option. Fibroids do not need to be treated if they are not causing symptoms. After the menopause, they'll often shrink without treatment. If you do have symptoms caused by fibroids, medicine to help relieve the symptoms will usually be recommended first. If these prove ineffective, surgery or other, less invasive procedures may be recommended. A myomectomy is an operation to remove fibroids while preserving the uterus. For women who have fibroid symptoms and want to have children in the future, myomectomy is the best treatment option. Myomectomy is very effective, but fibroids can regrow. One of the main tests carried out to diagnose fibroids is an ultrasound scan. Ultrasound. If confirmation is needed, your doctor may order an ultrasound. It uses sound waves to get a picture of your uterus to confirm the diagnosis and to map and measure fibroids. Two types of ultrasound scan can be used to help diagnose fibroids. An abdominal ultrasound scan where the ultrasound probe is moved over the outside of your tummy, abdomen. A transvaginal ultrasound scan where a small ultrasound probe is inserted into your vagina. Ultrasound. Many women are familiar with ultrasound from pregnancy when it is used to evaluate the growing fetus. Ultrasound is also a safe and reliable way to look for fibroids. In the test, sound waves are used to create a picture of the uterus and ovaries. Ultrasound does not use radiation. The procedure takes between 30 to 60 minutes. The initial portion of the exam is performed with a transducer on the abdomen. Conducting gel is placed on the skin, which feels wet and cool. The transducer is moved around as the technologist takes pictures of the uterus and ovaries. The second portion of the exam is performed internally. You will need to empty your bladder first. A special ultrasound probe will then be placed in the vagina. It is usually not painful and is inserted like a tampon. Close-up pictures are then taken of the uterus, endometrium, the lining of the uterus, and ovaries. The technologist reviews all the pictures and will report the results to your doctor. Images produced by these scans are transmitted to a monitor, so the doctor can see if there are any signs of fibroids. Whether a fibroid is symptomatic or not depends primarily on its size and location. During ultrasound examination, fibroids usually appear as well-defined, solid, concentric hypoechoic masses that cause a variable amount of acoustic shadowing. In general, large fibroids can compress the surrounding organs and tissues, for example the bowel, bladder, or pelvic ligaments, causing constipation, dysuria, or even back pain, by compressing the lumbar plexus. Large fibroids may also be palpable through the abdominal wall. Some fibroids may inhibit normal vaginal deliveries, causing hemorrhage or ulceration in the case of cervical localization. Submucosal fibroids may cause heavy bleeding if they protrude into the endometrial cavity and are usually the reason for long painful menstruation, with blood clots or abnormal uterine bleeding throughout the menstrual cycle. God bless you as we learn. If you don't understand any aspect, feel free to send your questions. Subscribe please for updates and follow up. Jesus. Biparietal diameter is one of many measurements that are taken during ultrasound procedures in pregnancy. It is one of the basic biometric parameters used to assess fetal size. Biparental diameter, together with head circumference, HC, abdominal circumference, AC, and femur length, are computed to produce an estimate of fetal weight. In the second trimester, this may be extrapolated to an estimate of gestational age and an estimated due date. It is a measurement of the diameter of a developing baby's skull from one parietal bone to the other. Biparietal diameter is used to estimate fetal weight and gestational age. The biparietal diameter is the maximum diameter of a transverse section of the fetal skull at the level of the parietal eminences. It can be measured in a thalamic plane or in a transventricular plane. The latter has the advantage that all three measurements, biparietal diameter, head circumference and ventricular atrium, can be taken in the same section. The calipers should be placed at the widest part of the skull, perpendicular to the midline echo. More than one technique has been described: outer edge to outer edge or outer edge to inner edge, and the reference chart should be chosen according to the technique used. Measurement technique. The BPD should be measured on an axial plane that traverses the thalami and cavum septum pellucidum. The transducer must be perpendicular to the central axis of the head, and thus the hemispheres and calvaria should appear symmetric. The calipers should be placed at the 1. Outer edge of the near calvarial wall. 2. Inner edge of the far calvarial wall. The cerebellar hemispheres should not be in the plane of the image. Fetal head size has been one of the most useful and proven measurements to determine gestational age. The biparietal diameter is the most widely used measure, with greatest accuracy between 12 and 22 weeks, declining after this period because of a wider individual variation. The biparietal diameter demonstrates linear growth of 3 mm per week from weeks 14 to 28 and 2 mm per week until term. The measurement is taken at the level of a plane defined by the following intracerebral landmarks. 1. The frontal horns of the lateral ventricle and cavum septum pellucidum anteriorly. 2. The thalami and third ventricle centrally, and the 3. Occipital horns of the cerebral ventricle, cisterna veni magni cerebri and insula posteriorly. Summarily, at each examination, biparental diameter images were acquired in the transthalamic plane, where the landmarks consist of the cavum septum pellucidum, thalami, and absence of the cerebellum. The measurement is taken from the outer table of the proximal skull to the outer table of the distal skull, with the cranial bones perpendicular to the ultrasound beam. Fetal head shape variations, dolichocephaly, brachycephaly, and fetal position can affect the diagnostic accuracy of biparietal diameter. Biparental diameter has been shown to be accurate in predicting gestational age from 14 to 20 weeks. The variability increases after this time. The biparietal diameter is considered to be an accurate ultrasound measurement of fetal growth from 10 weeks. The head-abdominal circumference ratio decreases with advancing pregnancy. Biparental diameter may also be influenced by factors such as abnormalities of head shape, breech presentation, or multiple gestations. Head circumference, HC, may be a more reliable measurement if there is variant head shape. Every human has two parietal bones, one on the left side of the skull and one on the right side. Each parietal bone looks like a curved plate that has two surfaces and four sides. Through fetal ultrasound, measuring biparietal diameter is extremely important because it can show fetal development such as indicate weight, gestational age, brain health status as well as the baby's development, and in the detection of fetal abnormalities. What happens when biparental diameter is low in pregnancy? A low biparental diameter can be an indication to monitor fetal head growth. Microcephaly can be a concern for women who may have been exposed to the Zika virus. If the biparental diameter falls 2 standard deviations below the mean, the head is considered to be excessively flat and microcephaly is suspected. Biparental diameter measurement is larger than expected, it could signal a health issue, such as gestational diabetes. Thanks for watching. God bless you. Please subscribe. Press subscribe button. Generic name: Levonorgestrel implants. Brand name: Jadel. Jadel is a prescription medicine used as contraception to prevent pregnancy. Jadel belongs to a class of drugs called estrogens, progestins, contraceptives, oral. Jadel may cause serious side effects including pain, swelling, bruising, scarring and infection of where the implant was inserted, ectopic pregnancy, thromboembolic disorders, high blood pressure, ovarian cysts, menstrual changes, yellowing of the skin and eyes, jaundice, depression, persistent headaches, and abnormal ab tests, globulin, thyroid. Get medical help right away if you have any of the symptoms listed above. Jadel, levonorgestrel implants, is a set of two flexible cylindrical implants consisting of a dimethylsiloxane-methylvinylsiloxane copolymer core enclosed in thin-walled silicone tubing. Each implant contains 75 mg of the progestin levonorgestrel. The implants are sealed with polydimethylsiloxane adhesive and sterilized. Each implant is approximately 2.5 mm in diameter and 43 mm in length. The implants are inserted in a superficial plane beneath the skin of the upper arm. The calculated mean daily in vivo release rate of levonorgestrel provided by the implants is about 100 mg/day at month, followed by a decline to about 40 mg/day at 12 months and to about 30 mg/day at 24 months, with a stabilization thereafter at about 30 mg/day. Jadel implants are a progestin-only product and do not contain estrogen. Jadel implants are indicated for the prevention of pregnancy and are a long-term, up to 5 years, reversible method of contraception. Both implants must be removed by the end of the 5th year. New implants may be inserted at that time if continuing contraceptive protection is desired. Following removal, fertility rates return to levels comparable to those in a population of similar women using no method of contraception. Jadel is likely to be less effective in obese women. Mean serum levonorgestrel levels decrease as weight increases, and the risk of pregnancy increases as serum levonorgestrel levels decrease. Insertion is subdermal in the mid-portion of the inner surface of the upper arm about 8 to 10 cm above the medial epicondyle. That is, Jadel is inserted just beneath the skin on the inside of your upper arm and is performed by your doctor. Although the implant may be removed at any time, it must be removed no later than 5 years after insertion. The Jadel rods are not radiopaque, so they are not visible on an X-ray or a computerized tomography (CT) scan. Therefore, to locate rods that are not palpable, use ultrasound or magnetic resonance imaging (MRI) techniques. The implant is about the size of a thin matchstick, and people have it inserted under the skin of the inner side of the upper arm. It can easily be felt, but it is not very visible, except to someone who is looking for it. During the scan, let the patient lie on the ultrasound examination bed in the reverse lying position. That is, head down and legs up. In this way, the patient's left inner upper arm will be exposed, since most Jadels are often inserted in the left upper arm, and in that position, the left upper arm is closer and accessible to the sonographer. The ultrasound gel is being placed on the arm at the desired position following the insertion scar or spot where the rods are palpable. The implant is best visualized by ultrasound on a transverse plane as an echogenic spot with a hypoechogenic shadow. Shown on the width arrow as above. Thanks for watching. I wouldn't like my viewers to get confused between implanins and norplants. Basically, implanin is used to prevent pregnancy for up to 3 years, and norplant is used to prevent pregnancy for up to 5 years. The brand name Norplant is discontinued. The brand name of the second-generation levonorgestrel implant product is Jadel, which is not available in the US. Please press subscribe button for follow-up and updates each time a video is uploaded. Press subscribe. God To begin, malpresentation is when your baby is in an unusual position as the birth approaches. Presentation describes how your baby is facing down the birth canal. Simply put, presenting part is the part of your baby's body that is against the cervix. Cephalic presentation means the fetus is positioned head down, facing the mother's back, with its chin tucked to its chest, and the back of the head ready to move towards the pelvis. The ideal presentation is head first, with the crown, top of the baby's head against the cervix, with the chin tucked into the baby's chest. This is called vertex presentation. If your baby is in any other position, it's called malpresentation. Malpresentation can mean your baby's face, brow, buttocks, foot, back, shoulder, arms or legs or the umbilical cord are against the cervix. It's safest for your baby's head to come out first. If any other body part goes down the birth canal first, the risks to you and your baby may be higher. Malpresentation increases the chance that you will have a more complex vaginal birth or a cesarean. Malpresentation is caused by your baby's position, lie. There are different types of malpresentation. 1. Breech presentation. Fetus in the longitudinal lie. This is when your baby is lying with their bottom or feet facing down. Sometimes one foot may enter the birth canal first, called a footling presentation. There are 3 types of breech presentation: complete, incomplete, and frank. Complete breech is when both of the baby's knees are bent and his feet and bottom are closest to the birth canal. Incomplete breech is when one of the baby's knee is bent and his foot and bottom are closest to the birth canal. Frank breech is when the baby's legs are folded flat up against his head and his bottom is closest to the birth canal. There is also footling breech, where one or both feet are presenting. Breech presentation is the most common type of malpresentation. 2. Face presentation. This is when your baby is head first but stretching their neck, with their face against the cervix. 3. Transverse lie. This is when your baby is lying sideways. Their back, shoulders, arms or legs may be the first to enter the birth canal. 4. Oblique lie. This is when your baby is lying diagonally. No particular part of their body is against the cervix. 5. Unstable lie. This is when your baby continually changes their position after 36 weeks of pregnancy. Cord presentation. This is when the umbilical cord is against the cervix, between your baby and the birth canal. It can happen in any situation where your baby's presenting part is not sitting snugly in your pelvis. It can become an emergency if it leads to cord prolapse. When the cord is born before your baby, potentially reducing placental blood flow to your baby. Thanks for watching. Please subscribe for more updates and notifications each time a lesson is uploaded. God bless you. Placental abruption is a condition during pregnancy when the placenta separates from the uterus. That is, basically, placental abruption is a complication of pregnancy that happens when the placenta separates from your uterus before delivery. The placenta is a temporary organ that connects a growing fetus to your uterus during pregnancy. It attaches to the wall of your uterus, usually on the topper side, and acts as a lifeline that gives nutrients and oxygen to the fetus through the umbilical cord. The placenta also removes waste from the fetus's blood. In placental abruption, the placenta may completely detach or partially detach. This can decrease the amount of oxygen and nutrients to the fetus and cause heavy bleeding in the birthing parent. Placental abruption is a serious condition that requires medical treatment. The different types of placental abruption are: a partial placental abruption occurs when the placenta does not completely detach from the uterine wall. A complete or total placental abruption occurs when the placenta completely detaches from the uterine wall. There is usually more vaginal bleeding associated with this type of abruption. Revealed placental abruptions have moderate to severe vaginal bleeding that you can see. Concealed placental abruptions have little or no visible vaginal bleeding. Blood is trapped between the placenta and uterine wall. About 1 out of 100 pregnancies has placental abruption. This condition is usually seen in the third trimester, but it can happen any time after 20 weeks of pregnancy up until delivery. Placental abruption can be life-threatening to the fetus and sometimes to you. Complications from a placental abruption include: for baby, premature birth, low birth weight, growth problems, brain injury from lack of oxygen, stillbirth. For birthing parent, blood loss, blood clotting issues, blood transfusion, hemorrhage, kidney failure. The cause of placental abruption is often unknown. Certain lifestyle choices or abdominal trauma can increase your risk for placental abruption. Trauma or injury to your uterus, like a car accident, fall or blow to the stomach. Each person can have different symptoms of placental abruption. However, the most common symptom is vaginal bleeding with cramping during the third trimester of pregnancy. Symptoms or signs can also include uterine contractions that are longer and more intense than average labor contractions, backache or back pain, decreased fetal movement. Vaginal bleeding can vary and is not an indication of how much the placenta has separated. In some instances, there could be no visible bleeding because the blood is trapped between the placenta and the uterine wall. Pain can range from mild cramping to strong contractions and often begins suddenly. There are typically 3 grades of placental abruption a healthcare provider will diagnose. Grade 1. Small amount of bleeding, some uterine contractions, and no signs of stress to you or the fetus. Grade 2. Mild to moderate amount of bleeding, some uterine contractions, and signs of fetal stress. Grade 3. Moderate to severe bleeding or concealed bleeding, uterine contractions that do not relax, abdominal pain, low blood pressure, and fetal death. Ultrasound is almost always the first imaging modality used to evaluate placental abruption. The sonographic signs of placental abruption include: 1. Retroplacental hematoma, often poorly echogenic. 2. Intraplacental anechoic areas. 3. Separation and rounding of the placental edge. 4. Thickening of the placenta. Often 2/5. 5 cm. 5. Thickening of the retroplacental myometrium. Usually should be 1 to 2 cm unless there is a focal myometrial contraction. 6. Disruption in retroplacental circulation. 7. Intraamniotic echoes due to intraamniotic hemorrhage. 8. Blood in the fetal stomach. 9. Intermembranous clot in twins. The echogenicity of hematomas depends upon their age. Acute hematomas imaged at the time of symptoms tend to be hyperechoic or isochoic compared to the adjacent placenta. As the hematoma is commonly isochoic to the placenta, it may be mistaken for focal thickening of the placenta. A normal ultrasound does not exclude a placental abruption, particularly as the blood may have escaped through the vagina in the case of external hemorrhage. In other cases, the retroplacental hematoma may be hypoechoic or of heterogeneous echogenicity. If an abruption is detected, then the larger the size of the abruption, the greater the fetal morbidity. The presence of associated concurrent fetal bradycardia carries a poorer prognosis. Management for small abruptions is usually conservative serial sonographic examinations, with measurement of the retroplacental clot volume, antepartum heart rate, and maternal symptoms has been suggested. Thanks for watching. God bless you. If you found this study interesting, then subscribe. Placenta accreta is a serious pregnancy condition that occurs when the placenta grows too deeply into the uterine wall. Typically, the placenta detaches from the uterine wall after childbirth. With placenta accreta, part or all of the placenta remains attached. What are the different types of placenta accreta? There are 3 types of placenta accreta. Providers determine the type based on how deeply the placenta is attached to your uterus. 1. Placenta accreta. The placenta firmly attaches to the wall of your uterus. It doesn't pass through the wall of the uterus or impact the muscles of the uterus. This is the most common type. 2. Placenta increta. In this type, the placenta is more deeply embedded in the wall of your uterus. It still doesn't pass through the uterine wall, but is firmly attached to the muscle of the uterus. Placenta increta accounts for about 15% of cases. 3. Placenta percreta. The most severe of the types, placenta percreta, happens when the placenta passes through the wall of your uterus. The placenta might grow through your uterus and impact other organs, such as your bladder or intestines. It accounts for about 5% of cases. This can cause severe blood loss after delivery. Placenta accreta is considered a high-risk pregnancy complication. If the condition is diagnosed during pregnancy, you likely need an early C-section delivery, followed by the surgical removal of your uterus, hysterectomy. That is, surgery is the most common and effective treatment for accreta. After the birth of the baby, this usually involves either the surgical removal of the placenta or a hysterectomy to remove the uterus along with the accreta. The ovaries are almost always left in place if a hysterectomy is performed. Placenta accreta often causes no signs or symptoms during pregnancy, although vaginal bleeding during the third trimester might occur. Occasionally, placenta accreta is detected during a routine ultrasound. Causes. Placenta accreta is thought to be related to abnormalities in the lining of the uterus, typically due to scarring after a C-section or other uterine surgery. Sometimes, however, placenta accreta occurs without a history of uterine surgery. Risk factors. Many factors can increase the risk of placenta accreta, including 1. Previous uterine surgery. The risk of placenta accreta increases with the number of C-sections or other uterine surgeries you've had. 2. Placenta position. If the placenta partially or totally covers your cervix, placenta previa, or sits in the lower portion of your uterus, you're at increased risk of placenta accreta. 3. Maternal age. Placenta accreta is more common in women older than 35. 4. Previous childbirth. The risk of placenta accreta increases as your number of pregnancies increases. Complications. Placenta accreta can cause a. Heavy vaginal bleeding. Placenta accreta poses a major risk of severe vaginal bleeding, hemorrhage, after delivery. The bleeding can cause a life-threatening condition that prevents your blood from clotting normally, disseminated intravascular coagulopathy, as well as lung failure, adult respiratory distress syndrome, and kidney failure. A blood transfusion will likely be necessary. Premature birth. Placenta accreta might cause labor to begin early. If placenta accreta causes bleeding during your pregnancy, you might need to deliver your baby early. Meaning, placenta accreta often leads to preterm birth. Preterm birth carries risks such as respiratory problems or trouble gaining weight. Babies born before 37 weeks of pregnancy have a higher risk of being admitted to a neonatal intensive care unit for specialized treatment. Now, after all the lectures, how do you diagnose placenta accreta on ultrasound? Placenta accreta represents the abnormal attachment of the placenta to the uterine lining due to an absence of the decidua bacillus and an incomplete development of the fibrinoid layer. Ultrasound findings suggestive of accreta include 1. Placental acunebe. 2. Myometrial thinning to less than 1 mm. 3. The loss of a placental uterine interface, and 4. An abnormal uterine bladder interface. The use of color and 3D Doppler ultrasound is also helpful in diagnosing placenta accreta. For example, an ultrasound may detect increased vascularity or blood flow that is beyond normal. May the great Almighty God bless us all. Thanks for watching. If you found this study interesting, please click on subscribe, like and share. Why do you subscribe? To be notified each time a video is uploaded. Thank you. Biparietal diameter is one of the basic biometric parameters used to assess fetal size. Biparental diameter, together with head circumference, abdominal circumference, and femur length, are computed to produce an estimate of fetal weight. In the second trimester, this may be extrapolated to an estimate of gestational age and an estimated due date, EDD. Biparietal diameter in fetus has been reported to correlate well with gestational age. Biparental diameter, aside being used to estimate gestational age, fetal growth, is also helpful in the detection of fetal abnormalities. The biparental diameter remains the standard against which other parameters of gestational age assessment are compared. The anatomical landmarks used to ensure the accuracy and reproducibility of the measurement include 1. A midline falx. The falx cerebri is a large, sickle-shaped infolding of the inner meningeal layer of the dura mater and lies in the midline of the skull. 2. The thalami symmetrically positioned on either side of the falx. 3. Visualization of the septum pellucidum at 1/3 the front occipital distance. That is, at each examination, biparental diameter images were acquired in the transthalamic plane, where the landmarks consist of the cavum septum pellucidum, thalami, and absence of the cerebellum. Measurement technique. The biparental diameter should be measured on an axial plane that traverses the thalami and cavum septum pellucidum. The transducer must be perpendicular to the central axis of the head, and thus the hemispheres and calvaria should appear symmetric. The calipers should be placed at the 1. Outer edge of the near calvarial wall. 2. Inner edge of the far calvarial wall. The cerebellar hemispheres should not be in the plane of the image. A wrong measurement plane can produce errors up to 20 mm. The biparental diameter measurement is obtained from outer skull bone to inner skull bone, leading edge to leading edge, perpendicular to the falx at the maximum diameter. A leading edge to leading edge measurement or a middle to middle measurement are both acceptable. The biparental diameter should be measured as early as possible after 13 weeks for dating. Interpretation. Biparental diameter has been shown to be accurate in predicting gestational age from 14 to 20 weeks. The variability increases after this time. Biparental diameter may also be influenced by factors such as abnormalities of head shape, breech presentation, or multiple gestations. Head circumference may be a more reliable measurement if there is variant head shape. If your baby's biparental diameter measurement is larger than expected, it could signal that a health issue, such as gestational diabetes. A low biparental diameter can be an indication to monitor fetal head growth. Microcephaly can be a concern for women who may have been exposed to the Zika virus. Also considered is macrocephaly. The biparental diameter can be smaller, and sometimes much smaller than is expected in fetuses with flatter heads. If the head really looks flat on the scan, check the head circumference and record the findings. If the value is within the normal range, then most likely the discrepancy is due to a flat head. Monitor the growth of the fetal head with the circumference from then on. The syplalic index will also be useful. If the value is below 74, the head is considered excessively flat. In cases of microcephalics, the biparental diameter is usually at least 2 standard deviation below the mean. Is biparental diameter accurate during the third trimester? The biparental diameter in third trimester is not reliable and be useless when the patient passes 30 weeks. In those cases, the biparental diameter has to be side with other measurements when we take it in later trimesters to emphasize the normal growth of fetus and avoid wrong measurement of ultrasound. The biparental diameter is useful for dating a pregnancy and in estimating intrauterine fetal weight in weight equation. The latter has the advantage that all three measurements, biparental diameter, head circumference and ventricular atrium, can be taken in the same section. The calipers should be placed at the widest part of the skull, perpendicular to the midline echo. Other than that, its value is limited and can sometimes be misleading in the assessment of growth in the fetus if it is the sole measurement taken for interpretation. Thanks. Dedicated to God Almighty. Subscribe for more. Crown rump length is the measurement to determine the length of human embryos and fetuses. The accuracy of the crown rump length in dating the pregnancy depends on good correlation between the measurement and fetal age in a period when growth is rapid and minimally influenced by fetal pathology. The crown rump length is the longest length of the embryo or fetus measurable excluding the limbs and yolk sac. The embryo becomes a fetus after 10 gestational weeks, that is, 71 completed days based on the LMP. The crown rump length is predictive of fetal age, with an error of 3 days, 90% confidence limits, from 7 to 10 weeks. And of 5 days from 10 to 14 weeks gestation. The crown rump length grows approximately 10 mm per week from weeks 8 to 12. In cases of multiple gestations, the crown rump length of the fetuses is the most important ultrasound parameter for dating of the pregnancy and, if necessary, to correct the gestational age in cases with a non-reliable menstrual history. The onset of early growth retardation in one of the fetuses may indicate a higher risk for chromosomal abnormalities. Normally, the crown rump length correlate between co-twins, although some degree of variability has been observed in multifetal pregnancies. Measurement of the crown rump length can easily be done at the time of the first trimester scan, 11 to 14 weeks of gestation. Later in pregnancy, correction of gestational age should be avoided, since growth curves in multiple pregnancies differ from those in singleton pregnancies beyond the second trimester. Crown rump length. Between 6 and 12 weeks gestational age, the measurement of the crown rump length of the embryo is most accurate for dating. The now classical study by Robinson and Fleming on crown rump length is still the main reference for the assessment of gestational age in early pregnancy. There are no significant differences with measurements made by the transabdominal route or the transvaginal route. Because transvaginal scan provides superior resolution and more accurate identification of the embryonic structures than abdominal ultrasound, new charts have been developed for the period of gestation before 7 weeks. To conclude then, the crown rump length is measured as the greatest length in a straight line from the cranial to the caudal end of the body, in the straightest possible position of the embryo fetus, excluding the limbs and the yolk sac. Thanks for watching. O God, enlighten the understanding of my followers. Amen. Please subscribe if you haven't so you get notified each time a video is uploaded. Thanks, subscribe, like and share to others who might be interested. Subscribe. The Ramsey theory is a strategy for using the location of the placenta during early pregnancy ultrasounds to predict the sex of a baby. Some people claim on online message boards that the method is as much as 97% reliable. Proponents refer to a study that involved a large number of ultrasounds. However, that study has not undergone peer review, and Dr. Sam Ramsey Ismail, who put his name to the theory, did not publish his research in a peer-reviewed journal. No major medical organization recognizes the theory as valid, and a 2010 study trusted source in a peer-reviewed journal disputes the notion that placental location correlates with sex. Sex differentiation, the process by which embryos begin developing male or female structures, begins early in development, usually about 6 weeks into the pregnancy. Proponents of the Ramsey theory argue that this means that it is theoretically possible to detect early indicators of sex well before a mid-pregnancy ultrasound might reveal this information. The theory began with an ultrasound study of 5,376 pregnant people who had ultrasounds at either 6 or 18-22 weeks of pregnancy. However, just 1,200 participants had both ultrasound scans. Researchers were able to see the external genitalia in 99% of male fetuses and 98% of female fetuses during the second trimester ultrasound. They found that 97.2% of male fetuses had a placenta on the right side of the uterus during the early ultrasound at 6 weeks, while 97.5% of fetuses had a placenta on the left side of the uterus. Drawing on this data, they concluded that a placenta on the right side usually indicates a male fetus, while a placenta on the left side is a sign that a fetus is female. This distinction is the basis of the Ramsey theory. Many message boards feature stories of people who used the Ramsey method to predict the sex of their baby correctly. Any sex prediction method has a 50% chance of being right, though, so anecdotal evidence is not reliable. Thanks for watching. Please subscribe. Subscribe, like, share. Thank you. Wow. Multiple pregnancy. Dichorionic, diamniotic. Baby boy for sure. An active baby. With fingers towards mouth. Intending to suck a finger. Thanks for watching. Anencephaly. Anencephaly is the absence of a large part of the brain and the skull. There are three types of anencephaly. 1. Moronencephaly, where there is rudimentary brain tissue and partial formation of the cranium. 2. Halonencephaly, the most common type, in which the brain is completely absent. And 3. Craniorachis. Craniorachis is a very serious neural tube defect, characterized by the combination of anencephaly, absence of the brain and cranial vault, without skin covering, with a contiguous bony defect of the spine, also without meninges covering the neural tissue. Rachis. Causes. Anencephaly is one of the most common neural tube defects. Neural tube defects are birth defects that affect the tissue that becomes the spinal cord and brain. Anencephaly occurs early in the development of an unborn baby. It results when the upper part of the neural tube fails to close. The exact cause is not known. Possible causes include 1. Environmental toxins. 2. Low intake of folic acid by the mother during pregnancy. Some babies have anencephaly because of a change in their genes or chromosomes. Anencephaly might also be caused by a combination of genes and other factors, such as the things the mother comes in contact with in the environment, or what the mother eats or drinks, or certain medicines she uses during pregnancy. The exact number of cases of anencephaly is unknown. Many of these pregnancies result in miscarriage. Having one infant with this condition increases the risk of having another child with neural tube defects. Symptoms of anencephaly are 1. Absence of the skull. 2. Absence of parts of the brain. 3. Facial feature abnormalities. 4. Severe developmental delay. 5. Heart defects may be present in 1 out of 5 cases. An ultrasound during pregnancy is done to confirm the diagnosis. The ultrasound may reveal too much fluid in the uterus. This condition is called polyhydramnios. On ultrasound examination of the fetus, the calvaria and brain parenchyma are not visualized. Biparietal diameter and head circumference cannot be measured. A coronal section through the fetal face shows frog-like bulging of eyes and absent frontal bones. An anencephalic fetus has a triangular-shaped face and lacks the anterior region of the skull, both of which can be seen on the sonogram. Fetuses with anencephaly are correctly identified at 12 to 13 weeks gestation. Anencephaly occurs in absence of the cranial vault. Ultrasound findings can be normal until onset of ossification has definitely failed. A first trimester scan at 12 to 13 weeks allows reliable diagnosis and active management of anencephaly. Summarily, how do you identify anencephaly? What are the symptoms of anencephaly? 1. Absence of bony covering over the back of the head. 2. Missing bones around the front and sides of the head. 3. Folding of the ears. 4. Cleft palate, a condition in which the roof of the child's mouth doesn't completely close, leaving an opening that can extend into the nasal cavity. The mother may also have these tests during pregnancy. 1. Amniocentesis, to look for increased levels of alpha-fetoprotein. Alpha-fetoprotein level, increased levels suggest a neural tube defect. 2. Urine estriol level. 3. A pre-pregnancy serum folic acid test may also be done. Prevention. There is good evidence that folic acid can help reduce the risk for certain birth defects, including anencephaly. Women who are pregnant or planning to become pregnant should take a multivitamin with folic acid every day. Many foods are now fortified with folic acid to help prevent these kinds of birth defects. Getting enough folic acid can cut the chances of neural tube defects in half. Thanks for watching. Please subscribe, like, comment and share. Ask questions. Hello everyone. This is ultrasound made easy. Now we will be looking at baby girl sex at 20 weeks of pregnancy. As technology advances, seeing the vulva, clitoris, and labia are taken to indicate a female fetus. Seeing the internal pelvic structure of the fetus, including the uterus and ovary, is also used to help identify the fetal gender. There is a substantial chance of getting a false negative diagnosis if the ultrasound imaging for fetal gender identification has been performed in the first trimester of pregnancy. However, research suggests a better sensitivity of ultrasound imaging for fetal gender identification, performed in the second trimester of pregnancy. The sensitivity depends on the operator, machine, and habitus involved, and it increases with the radiologist's experience, and if ultrasound imaging is performed using the high-resolution machine. Rather than the dome sign, seeing what looks like 3 light layered lines, also called the hamburger sign, in the genital area indicates a girl. Those lines are the labia majora, the clitoris and the labia minora. You will see that the labia lips look similar to a hamburger bun, while the clitoris resembles a hamburger patty. Thanks for watching. Please subscribe, like and share. Spina bifida literally means split spine. A fault in the development of the spinal cord and surrounding bones, vertebrae, can leave a gap or split in the spine. The spinal cord does not form properly and may also be damaged. Diagnosis of spina bifida requires the systematic examination of each neural arch, from the cervical to the sacral region, both transversely and longitudinally. In the transverse scan, the normal neural arch appears as a closed circle with an intact skin covering, whereas in spina bifida the arch is U-shaped, and there is an associated bulging meningocele, thin-walled cyst, or melomeningocele. The extent of the defect and any associated kyphoscoliosis are best assessed in digital scan. The site of open spina bifida are 1. Lumbosacral, 65%. 2. Sacral, 24%. 3. Thoracolumbar, 10%. 4. Sacral, 24%. 5. Thoracolumbar, 10%. 6. Cervical, 1%. Open spina bifida is associated with the Arnold-Chiari II malformation, with caudal displacement of the brain stem and obliteration of the cisterna magna. At 11 to 13 weeks gestation, in the mid-sagittal view of the head, the lower part of the brain between the sphenoid bone anteriorly and the occipital bone posteriorly can be divided into the brain stem in the front and a combination of the fourth ventricle and cisterna magna in the back. In most cases of open spina bifida, the diameter of the brain stem is increased, the distance between the brain stem and the occipital bone is decreased, and the ratio of the brain stem to occipital bone is greater than 1.0. In the second trimester, more than 95% of fetuses have frontal bone scalloping, lemon sign, and obliteration of the cisterna magna, with either an absent cerebellum or abnormal anterior curvature of the cerebellar hemispheres, banana sign. A variable degree of ventricular enlargement is present in virtually all cases of open spina bifida at birth, but in only about 70% of cases in the mid-trimester. Supplementation of the maternal diet with folate, 5 mg day, for 3 months before and 2 months after conception, reduces the risk of recurrence by about 75%. Thanks for watching. Please subscribe for more. Case 1. A patient presents at the ultrasound unit with a request for a scan. Patient complains of persistent right iliac fossa tenderness. The doctor requests an abdominopelvic ultrasound, suspicion of appendicitis. Lying on the ultrasound examination bed, patient has a bulky abdomen. Performing the scan, as showed, reveals a gravid uterus with a viable monofetal intrauterine gestation. The biparental diameter, head circumference, abdominal circumstances and femur length averagely dates 21 weeks 04 days. A posterior placenta, not touching the cervix, thus excluding previa. This female patient, aged 26 years, says but the pain is bearable. Thorough scan through the fetal scan is normal. No abnormality of the head, abdomen, spine, limbs, amniotic fluid and of cardiac chambers seen. Fetal parameters are very much within normal range with regard to this gestational age. A scan from uterus to adnexa reveals a normal adnexa. Then the appendix, interesting. Challenging locating the appendix with a gravid uterus. This appendix measures 2 mm within the normal range of less than 6 mm. Its texture on ultrasound is normal, not hypervascularized. Thus this patient most likely might be having pains resulting from ligamentous strains. Thanks for watching. Subscribe for subsequent cases. Subscribe. Gestational trophoblastic neoplasia. Gestational trophoblastic neoplasia is a collective term for gestational trophoblastic diseases that invade locally or metastasize. Hydatidiform mole is the most common form of gestational trophoblastic neoplasia. Trophoblastic diseases. The World Health Organization classification divides trophoblast diseases into pre-malignant and malignant forms as shown. 1. Pre-malignant. These include partial molar pregnancy and complete molar pregnancy. 2. Malignant. These include invasive mole, choriocarcinoma, placental site trophoblastic tumors, and epithelial trophoblast tumors. As described previously, hydatidiform moles arise from gestational tissue. In complete hydatidiform mole, there is no fetal tissue present. In partial hydatidiform moles, there is some residual fetal tissue. Both are due to the overproliferation of chorionic villi. Now to begin, we are dealing with partial hydatidiform mole. Partial hydatidiform mole is a type of molar pregnancy, which in turn falls under the spectrum of gestational trophoblastic disease. Clinical signs and symptoms such as abdominal pain, cramps of the lower abdomen and vaginal bleeding during pregnancy are common, but non-specific. The uterus is often large for gestational age, and fetal heartbeat is usually absent. It is characterized by its focal distribution, slower transformation, the presence of an embryo or fetus. On ultrasound, definitive diagnosis by ultrasound is often difficult. Described sonographic features include 1. Greatly enlarged placenta relative to the size of the uterine cavity. 2. Cystic spaces within the placenta, molar placenta, which may not always be present. 3. An amniotic cavity, gestational sac, either empty or containing amorphous inappropriately small fetal echoes, which may be surrounded by a relatively thick rim of placental echoes with intermingling cystic spaces. 4. presence of a well-formed but growth-retarded fetus, either dead or alive with degeneration of fetal parts being frequently hydropic present. 5. Some partial moles can have sonographic appearances indistinguishable from those of the common complete moles or missed abortions, although an echogenic rim around the sac, as found in missed abortion or anembryonic pregnancy, is notably absent. 6. Color Doppler interrogation may show high velocity and low impedance flow. When a partial mole is suspected and there is a live fetus, counseling and genetic tests looking for triploidy should be offered, chorionic villa sampling or amniocentesis. Suction and curettage are used for evacuation. Notably, differential diagnosis are very essential. As in, fetal demise with placental hydropic change. But beta-HCG levels are invariably low in this case. Secondly, twin pregnancy with one normal twin and one complete hydatidiform mole. The normal twin usually has its own normal placenta. Thanks for watching. Subscribe for more lessons. Subscribe. Ultrasound diagnosis of ectopic pregnancy. Role of ultrasound. Non-tubal ectopic pregnancy. As previously mentioned, 5% of all ectopic pregnancies are non-tubal. However, they contribute disproportionately to the morbidity and mortality in women with an ectopic pregnancy. We will now describe the different non-tubal ectopic pregnancies, their locations and their ultrasound appearances. 1. Interstitial pregnancy. Ultrasound diagnosis is based on the absence of an intrauterine pregnancy, with the presence of trophoblastic tissue located outside of the endometrial cavity. That is, in that part of the fallopian tube which traverses the myometrium. Interstitial pregnancies are surrounded by a thin myometrial mantle, or continuous rim of myometrium. Traditionally, these tended to rupture at between 8–16 weeks because of the greater distensibility of the myometrium compared to the fallopian tube. These pregnancies are highly vascular with blood supply from both the ovarian and uterine vessels, and when rupture occurs, hemorrhage is profuse. Interstitial pregnancy, the gestational sac is located 1 cm lateral to the endometrium in a woman with a subseptate uterus. 2. Cervical pregnancy. Cervical pregnancy is rare, with an incidence of 1 in 8,600 to 12,400 pregnancies. Ultrasound diagnosis is based upon an empty endometrial cavity, the cervix is barrel-shaped, and the gestational sac is implanted below the level of the uterine arteries, that is below the level of the internal cervical os. There is an absence of a sliding sign. When pressure is applied to cervix using the probe in a miscarriage, the gestational sac slides against the endocervical canal, but does not do so in a pregnancy implanted in the endocervix. 3. Ovarian ectopic pregnancy. Ultrasound diagnosis. An ovarian ectopic pregnancy may be difficult to distinguish from ovarian germ cell tumors or other ovarian pathology. A high index of suspicion is based upon a combination of ultrasound findings, both grayscale and with color Doppler, as well as high levels of serum HCG and sonographic experience. Nearly a third of women present with hemodynamic instability because of rupture. Diagnosis is based on the classic description of a cyst with a white echogenic outer ring. Ovarian ectopic pregnancies are most often treated surgically. 4. Caesarean section scar ectopic pregnancy. Caesarean section scar ectopic pregnancy seems to be diagnosed more than ever. Ultrasound diagnosis is based upon an empty endometrial cavity, and the gestational sac is located in the lower anterior myometrium at the level of the previous caesarean scar. As with the cervical pregnancies, the sliding sign is absent. 5. Heterotopic pregnancy and 6. Bilateral tubal ectopic pregnancy. However, the rate may be as high as 1 in 100. Early detection not only prevents maternal morbidity and mortality, but may also permit the salvage of the intrauterine pregnancy. Bilateral tubal ectopic pregnancies are very rare, with an estimated prevalence of 1 is to 200,000. Summary ultrasound diagnosis of ectopic pregnancies using transvaginal scan is not only expected in the 21st century, but should be the benchmark standard for all units involved with early pregnancy ultrasound. Early ultrasound diagnosis of ectopic pregnancies decreases mortality, surgical intervention, and enables non-surgical conservative treatments to be offered. Laparoscopy is not necessary as a diagnostic tool in the modern management of women with ectopic pregnancies. Transvaginal scan is the new gold standard and diagnostic tool of choice for all forms of ectopic pregnancies, both tubal and non-tubal. The vast majority of women who present with an ectopic pregnancy can be diagnosed reliably using transvaginal scan as a single standalone test. Thanks for watching. You indeed learn a point. God bless you. Please kindly subscribe for more. Subscribe. The Ramsey theory. The Ramsey theory suggests that the gender of a fetus can be seen as early as 6 weeks by looking at which side the placenta develops. According to the theory, if the placenta develops on the right, you are likely to have a boy, and if the placenta is on the during an ultrasound, it can be quite difficult to see exactly where the placenta is forming at 6 weeks. During the development of the theory, they used color Doppler to establish the site where the chorionic villi were forming. Without the use of color Doppler, it would probably be more clear if the cord insertion is clearly visible. A specific view would need to be obtained to see this, that is, a transverse view which effectively shows a view as if looking through a cross-section of the uterus from the top, and when looking at the screen remember left is right and right is left. Just to confuse things, orientation is never what you think it is with ultrasound. With this view you can see which is left and which is right. The Ramsey theory should be considered a bit of fun when looking at the gender of your baby, and we certainly wouldn't recommend going and spending money on outfits and nursery decor, simply because it is a theory and has not yet been proven or endorsed. We can only suggest that you take online and look at what mums-to-be are saying, which in a lot of cases, the Ramsey theory has proven to be incorrect. At the same time, there is only a 50/50th chance of accuracy, and we also don't know if the scans that they have undergone have used the correct views and have made accurate assessments of the placental location. Thanks for watching. Please subscribe for updates. How to tell a baby's gender from an ultrasound. During pregnancy, many doctors are able to help parents with an ultrasound to determine the baby's biological gender, which is very exciting. Once you find out whether the baby will be a boy or a girl, you can throw a gender reveal party. It also gives you and your partner plenty of time to think of a name. However, it should be noted that the accuracy of the ultrasound really depends on how many weeks the woman has been pregnant. The longer means the easier it is to be sure of the baby's gender. It takes some expertise to read an ultrasound, so you'll definitely want to have the technician or doctor give you the results. They can explain exactly what you're looking at, so you'll be able to better understand what you're seeing. Trick 1. Asking the technician or doctor to explain the results. Ask the technician to show you what they are looking at. If you say you want to know the gender, the technician will be happy to tell you. However, you'll need to make it clear that you don't want to just know the results, you want to understand them. You can say something like, "Can you show me exactly what indicates the gender? Can you explain to me how you can tell? I really appreciate it." Trick 2. Inquire if the technician can use nub theory at around 11 to 12 weeks. The gender tubercle is a body of tissue that indicates the formation of the genitals. This is commonly referred to as a nub. If the nub is angled upward, the gender is likely male. If the nub points straight out or down, it is more likely female. Sometimes the nub won't be visible, and the technician won't be able to see it. That doesn't mean that anything is wrong. You'll just need to wait until your next ultrasound and hope that it will be visible then. You probably won't be able to identify the nub with an untrained eye. Ask the technician to point directly to the nub and show you the angle. Trick 3. Note the presence or absence of a penis at 18 to 20 weeks. Once you reach the 18 to 20 week ultrasound, it should be a lot easier to predict gender. The easiest way is to look for a penis. If you see one, there's an excellent chance the gender is male. The absence of a penis indicates female. You might be able to identify a penis on your own, but it's still a good idea to ask the technician if you're looking at the right thing. Keep in mind that sometimes another body part, like a finger, might be mistaken for a penis. The position of the fetus can sometimes make it difficult to tell for sure what is what. Trick 4. Ask about advanced visualization to identify gender. Advances in technology have greatly improved how accurately ultrasounds can show gender. If your technician uses 2D imaging, they might be able to visualize additional parts of genitalia. Ask the technician to point out the vulva, clitoris, and labia if they think the gender is female. Try to identify the scrotum and testicle of a male with the help of the technician. 3D and 4D ultrasounds provide a much clearer picture of the baby at 18 to 20 weeks. However, they are completely optional, as they do not actually make it easier to determine the gender. Although ultrasounds are safe, you should only have them when necessary. Many people get 3D or 4D ultrasounds as a keepsake, but many doctors advise that it's better to wait to snap photos after the birth. Also, insurance might not cover the expense. Trick 5. Ask about the gender at 11 to 12 weeks, knowing that it might not be possible to tell. You can ask if it is possible to use the nub theory at the end of the first trimester. However, the ultrasound might not show the nub. You should also know that gender predictions at this point are much less accurate than they will be later in the pregnancy. Ultrasounds early in the pregnancy are generally to monitor the health of the baby and check for any issues. They're not intended to be able to reveal the gender. Trick 6. Expect to learn the gender at a 20-week ultrasound. The second or third trimester ultrasound can more accurately predict gender. When you go for your 18 to 20-week ultrasound, let the technician know that you would like to know the gender. Remember to ask them to show you exactly what they are looking at. Trick 7. Accept that you have to wait for the birth to be 100% sure about the gender. Ultrasounds at 18 to 20 weeks might be anywhere from 88 to 98% accurate. That's pretty good, it's about 10% less than earlier in the pregnancy, but there is still a margin of error. It might be tough, but you'll have to wait for the actual birth to know for certain. The position of the fetus or just a simple error on the part of the technician can result in predicting the wrong gender. I really want a baby boy. Is there anything my husband and I can do? Remember, there is still a chance of a girl even after using the suggestions.